we don't really say replacement therapy anymore and for lots of reasons. Professor Pryor, who I mentioned earlier, she points out if you accept that the drop to lower estrogen is normal and not a disease and not a deficiency, then replacement isn't the right word. So most experts agree with that now. It's called menopausal hormone therapy, and it's the option to use, mainly they're talking about estrogen. Yeah, the decision to do it should be quite personal. I mean, I don't know how many of your listeners are in the UK, but the UK in particular, this last couple years has been having the pendulum has been swinging over the last few decades to, when I started practicing in the 80s, like in the 90s, it was like, oh, everyone should be on estrogen. It prevents heart disease. It's like, take it unless you can't for whatever reason. And then obviously, it swung because of arguably quite a flawed study. It swung all the way to the other side. Everyone was very scared of taking estrogen. And now it's, especially in the UK, it's swung like really far back the other way, that everyone should take it. That this sort of narrative that, menopause is a disease state, that you need estrogen. So that's the pendulum swinging too far. So I think there is a middle ground there, which is that modern hormone therapy, which is body identical, which means hormone estradiol, our main estrogen, and progesterone are identical to the body's own estradiol and progesterone, which is actually quite different than the hormone therapy that was used back in the 90s when I started practicing. That's mostly mainstream now. So in the UK, body identical progesterone is called utrogestin. So yeah, essentially, I think a reasonable moderate dose of body identical hormone therapy is pretty safe. It's pretty darn safe. So then the question is, should you do it or not? Like if someone has early menopause, I would say yes, do it, unless there's a reason not to. If you're younger than 40, you're definitely going to need some estrogen for at least for a while. If you have like risk factors for osteoporosis, then yes, probably use estrogen and progesterone. If you have strong symptoms, then do it. But in terms of this sort of long-term disease risk reduction, dementia, that is still being investigated. And it's possible that taking the hormones could reduce the risk. But I'm going to try to explain this to you. I see if this makes sense given all the conversation we've already had. What makes sense to me as a biologist is that estrogen therapy is more likely, in terms of disease risk reduction, estrogen therapy is more likely to be helpful for women who have insulin resistance, or like women who are not metabolically healthy. Does that make sense? Because I talked about how with the drop in estrogen, we have to recalibrate our metabolism. And if we can do that, if we're, in the right food environment, and then we're fine. And like, this is why the Hadza come through menopause with no problems at all. Like they don't have measurably increased disease risk from it. But because of all the other factors, the evolutionary mismatch, it could be in that case that you're kind of mitigating that mismatch by taking estrogen. Does that make sense? That's kind of, yeah.
Yeah, it does. It's good to
Yeah.
bring that back in from the insulin resistance we mentioned before.
Yeah. So short answer, I think it's okay to take it if the doctor says it's safe. I also think it's okay to not take it. And also because there are lots of other ways to feel better. And so I don't feel like women should feel pressured or scared or feel like, they have to take it. Like chances are, I mean, women outlive men anyway. Like most women, even without hormone therapy, are likely, going to live into their 80s and 90s. That's sort of just biologically what we're capable of. So I don't think hormone therapy has to be part of that picture. And for what it's worth, in Hormone Repair Manual, I do talk about potentially the role of using progesterone, body identical or bioidentical or natural progesterone on its own for certain symptoms, especially during the perimenopause transition, for lightening periods, for preventing migraines, for sleeping. Progesterone on its own, even without estrogen, can be quite helpful. That's sometimes a little tricky to get from the doctor because they don't like giving progesterone without estrogen for reasons that we won't get into right now. But that may change going forward. And progesterone is very safe. And again, I'm talking about real progesterone, not progestins. I mean, just a word on that, actually, the old school hormone drugs therapy that were trialed in the Women's Health Initiative and did so badly and, increased breast cancer risk potentially and all these things. They now think most of that risk was from the progestin, not from the estrogen they were giving at the time. So, whereas progesterone is quite different and has become mainstream because it's safer for breasts than progestin.